in healthcare who deal with healthcare directly need to be engaged and involved with shaping and changing how healthcare is going to become. We can all have our own opinions on the Affordable Care Act and what it means to us, but it is up to us to shape it in a way and implement it in a way so that it is successful. And so I'm really glad to see many of you who I've known over the years here in the audience and really talk about how we're going to be working together. One of the big things is the Medicaid expansion, so I'm going to touch upon that, but before we go into that, it's going to be important just to talk about where we are as a healthcare system. And how do I advance it? No way.
No remote?
No, isn't there an arrow here? Okay. Okay, this is good. So, this isn't new news for everybody. The healthcare costs in our country, over $2.5 trillion, and it represents about 18% of our GDP. It is unsustainable. There is no other healthcare system in the entire world where there is a bottomless pit when it comes to healthcare expenditure. And in our country, that's really the situation we're faced with. We're 50% more than the next country in terms of healthcare spending. As I said, we do spend about 18% of our GDP, and that's great if we get the value for what we're spending. But when you look at the global healthcare quality measures like life expectancy, or you look at measures like infant mortality, we're somewhere in the second quartile in country rankings across the world when it comes to our healthcare quality. In addition, a lot of you are familiar with the Dartmouth report, where there's variation across the country. So there are places where we're spending 3 times more than the average spend on healthcare, and the quality that we get is about the same. So we're spending more, the variation is higher, whereas expenditure is higher, but the quality is, if anything, mediocre. So it's really unsustainable, and truly healthcare reform has to happen. So what are some of the challenges in our healthcare system? And the challenges in our healthcare system are very similar to the challenges that we face here in New Jersey. We have the burden of chronic illness, we have an aging population, we have an increase in diversity, physician workforce shortage, and I would like to expand that to healthcare professional workforce shortage, which includes the nurses specifically, and we have a lagging health information technology system. So when you look at the burden of chronic illness, and I'm just hoping this is visible, we see that just in the state of New Jersey today we're spending $63 billion in healthcare. And this is only going to go up with every decade. And the reason why that's happening is chronic illness contributes to about 78% of healthcare dollars spent. So when you look at hospitalizations, that represents about 76% of healthcare dollars spent, 88% of all prescription drugs go to treating chronic illness, and 72% of visits go to treating chronic illness. Yes?
What is your definition of chronic illness?
Chronic illness is anything where you have a disease that will continue to progress. So anything that is not cured or treated, like an infection, constitutes a chronic illness.
Would diabetes be?
Absolutely. Diabetes, heart disease, high cholesterol, chronic obstructive pulmonary disease, asthma, cancer, all these are chronic illnesses for which disease will continue to progress. And when you look at our healthcare system, it does an absolutely fabulous job when taking care of an infection, right? So if you have a sore throat, you have a bronchitis, you have a urinary tract infection, we do a really great job treating those things. But when we talk about a chronic illness where you have multiple providers having to work together to prevent the progression of disease that is not really going to get cured, but we can prevent the progression of it, that's where we fail as a system. And so that's really what constitutes a chronic illness. And we do a great job with acute care, but we don't do a good job with chronic care because there are multiple players in our healthcare system that don't talk to one another. There's a lot of duplication, there's a lot of non-value added testing and interventions that are done as a result of it. And if you look at our population, 50% of Americans have a chronic illness today. So when you look at our entire population, half of us have some kind of chronic illness. And so when I talk about chronic illness, I really do like to talk about, as you age, your chronic illness burden increases. And one of the big passions I had when I was in office was around long-term care. and the importance of seeing if we can rebalance our long-term care so that patients and people can live at home with dignity and autonomy. I'm still a practicing physician. I work at the VA hospital. I work in the nursing home there. And I know from first-hand experience how these patients could really be transferred, or if we provided a system where they could stay stable and healthy and independent to the community, they would not only have better longevity, but also better quality of life. And so how do I reshift that balance? And the Assemblywoman knows about some of these initiatives that we have in place, but how do we reshift it so that patients are not institutionalized, but we're providing community and home-based resources so that they do stay at home? We as a state don't do well in it. We are improving. We were 90-10 in terms of our long-term care dollars. So the pink bar, the tall pink bar, is the dollars that are going to spend in institutions for long-term care services, and the small red bar is the dollars that go to helping patients stay in their home and community. So in 2003, we were spending 90% of our healthcare dollars in the institutions. We've been able to shift it as a state, and in 2010, we shifted it to 70% of those dollars being spent in institutions and 30% in the state, 30% at the home. Now, the best in the country actually has this reversed. So states like Washington, for instance, spend 70% of their dollars to bring resources and solutions to patients who are elderly to stay at home, versus 30% of dollars to pay for institutional care. So I think there's a lot of room for us to improve. The average in the country is about 60% in institutions. So we really do have not only an opportunity, but really a lot of room to grow when it comes to some of the things that have already taken place and how we can maximize on that. The diversity of our state is something that we all are aware of. We are the third most diverse state in the country. 30% of the population speaks a language other than English at home. The biggest population boom in the state has been as a result of the new immigrants that have been coming into the state. So with that, what happens? With that, we have to understand what the barriers are in communication and implementing a care plan. With that, we have to understand the challenges of disease prevalence and incidence. And so there are certain kinds of cancers, heart disease, diabetes, all kinds of chronic illnesses that are prevalent in certain ethnic segments of our population. So we have to prepare not only for the chronic disease prevalence, the longevity, and New Jersey is one of the top 10 states when it comes to the 65 and older population in numbers in the state. So we have an aging population, we have a browning population, we have a graying population, we have a system that's fragmented, we have a lot of variation, one of the most high-cost states, and then on top of it, we have fragmented care. So when you look at some of the national metrics, we do the worst when it comes to the number of providers a patient sees in the last 6 months of his or her life. So we actually rank number 1 in that category. So we're seeing about 11.3 providers in the last 6 months of a patient's life, when at that time the patient really should be home and really doing what he or she would always want to do in terms of quality of life, no matter what stage that person is in. So there are lots of confounding factors that are affecting our healthcare system, and so we do have a lot of challenges, but with challenges are opportunities. Now, what's happening to the physician population? And that's something, again, that I've always talked about, no matter where I've been. 12% of medical students who go to New Jersey medical schools plan to practice here. So we have about 88% of the New Jersey medical students actually leaving the state after we've invested in their education and their nurturing and hopefully wanting them to contribute back and give back into our communities. 32% of residents who go through the actual training plan to stay here. So we have an environment where it is not conducive for our physicians to actually stay here. And with the increasing insured population, the deficit's going to actually escalate. So today we have about a shortage of 1,000 physicians in our state. If we're going to be seeing the expansion as we're predicting in terms of insured population, whether it's through the exchanges or through Medicaid, the need is going to go up tremendously in terms of the shortages that we're going to see.
Question.
Sure.
Why is that happening? Why are only 12% of those medically educated here stay here?
Well, it's a lot of factors that we see happening. The environment of practice is not that conducive. The malpractice environment, is not that great in terms of some of the things we've done around tort reform. We haven't implemented. Other states have. There are other states that have great and rich loan redemption programs. It is a very specialty-driven state. So primary care, and that's where we have the biggest need, is not welcomed with open arms. So they do tend to leave where they can have more autonomy, less regulation, and have a better cost of living, but at the same time an improved income level. So, and most importantly, I think, when I've looked at some of these surveys, and the most valuable part of the surveys is what you see, what they write in their responses, is that when they see their mentors, their attendings, their physicians who they're training under unhappy, or not satisfied, or complaining about the work environment, then they really do tend to say, well, do I really want this for the rest of my life? Those are the facts, but there's a lot that's happening to improve that. So I do want to leave an optimistic picture where this is the state of affairs, but it doesn't mean that we're going to stay like this. We're going to be continuously improving. One of the things that I think is important for physicians that we really have to touch upon as a state is looking at ways where we not only make primary care the focus and make it a primary care-driven model, but also identify ways by which they feel continuously challenged in their professional careers. And so, if you look at the state of New Jersey, we are the mecca of research and development, right? With all the global pharmaceutical companies here. So to give them opportunities where they're actually enhancing their professional growth and able to contribute in many different ways is one thing in terms of how we as a state can help with that. So giving them different kinds of experiences so that they're not just in the trenches. A lot of the new physicians are going to specialties called ROAD. The ROAD specialties are the radiology, anesthesia, ophthalmology, and dermatology specialties. And they're doing that because they want a better work-life balance. They don't want to be, working the 60, 70 hours a week that folks from my generation and before worked, right? So they want that kind of experience. So we're going to see a lot of change in terms of how we're meeting the needs of our workforce. And just last night I was with a group of physicians and we were talking about medical homes and how there are programs around the country where they're actually coming up with these special interdisciplinary teams where you take care of the sickest patients, right? The patients who have difficulties with preparing meals, transportation, have no one taking care of them, have lots of different, types of, chronic illnesses like diabetes or heart disease. And those are the patients where, in my mind, the nurse practitioners do the best job because physicians like to go in there, treat, and walk away, right? But then there are certain types of illnesses where the patients and education and empowering them becomes so much more important, the social aspect of care. And that's where I think the nurse practitioners play a key role. So it's about looking at your workforce, aligning them, and bringing them together in a way that the final solution meets the needs of your community.